1/3, more than 1/3 for patients, right? And if you look at that LP-litera's toxicity, we are just above the Africans. Europeans don't care, right? 10 to 15%. Ours is 20 to 35%, and that translates into 2 to 3 times higher of premature MIs, right? So just keep that in mind. Now, LP-little is unaffected by Dr. Jaber's statins, diet, SGLT, GLP-1, whatever you're talking about, you're born with it, and unless you give some inclisiran or some of the new LP-little drugs coming, you don't get benefit. And from there, let us look into the Asprin database, the new data that came in Journal of American College of Cardiology, that talks about aspirin for primary prevention, cardiovascular events in those who have a high LP-little genotype. So what they looked into the same Asprin data was this. They looked at LPA levels by LPA-GRS. They looked at the LPA genetic marker of RS3798220C, which is a carrier state for LP-little, and whether they were receiving, half of them were on aspirin. Obviously, aspirin data showed that aspirin has no benefit, right? And they looked into this data between aspirin 100 and those who were taking placebo. They looked at MACE rate and bleeding. We know that bleeding increases and MACE rate is no different. And yes, this is what Dr. Jaber very clearly showed us. All those 12,815 people, no difference. Green is MACE of aspirin and red is bleeding rate, similar, no benefit, right? But when they looked at those who carried the gene of RS3798220C carriers, you very clearly see the difference. The MACE reduction was huge and the bleeding slightly more, right? So plus 8.1 even benefit. This is net benefit of aspirin. What about those who had their LP-little levels done? Similar thing. Net benefit of